"Excuse me, you can't prescribe that medication." The sharp voice of head nurse Patricia Williams cut through the emergency room like a scalpel as she stepped between the young black doctor and his patient's bedside. "I don't know who you think you are, but only senior physicians can authorize those dosages." Dr. Marcus Johnson looked up from the chart he was updating, genuinely surprised to find the 20-year veteran nurse blocking his path with crossed arms and an expression of absolute authority. "I'm sorry, but this is the correct treatment protocol," he said calmly, though his voice carried a quiet confidence that irritated Patricia immediately. "Treatment protocols are determined by qualified doctors, not residents who think they know better," Patricia replied sharply, loud enough for nearby staff to hear. But what Patricia didn't know was that she had just challenged the hospital's new chief of emergency medicine, and in exactly 30 minutes, her career was about to change forever. Memorial General Hospital's emergency department represented the pinnacle of critical care medicine in downtown Detroit, a place where life and death decisions were made every minute, and only the most skilled medical professionals were trusted to work. The 60-bed emergency department hummed with controlled urgency, filled with the steady beeping of monitors, the urgent conversations of medical staff, and the quiet determination of people fighting to save lives around the clock. Located on the hospital's ground floor, the emergency department served as the front line for the most critical patients in the region, from trauma victims to cardiac emergencies requiring immediate intervention. The department operated with military precision, where every second mattered, and protocols existed to ensure the highest standards of patient care. Head nurse Patricia Williams had worked in the emergency department for 20 years, rising from floor nurse to head of emergency nursing through what she considered her unwavering commitment to proper medical procedure. At 48, Patricia took enormous pride in maintaining the department's reputation for excellence, and she'd developed very specific ideas about medical hierarchy and who had the authority to make critical treatment decisions. Patricia had seen dozens of residents and young doctors rotate through the emergency department over the years, and she'd learned to spot the overconfident ones who thought they could shortcut established protocol. In her experience, young doctors often made dangerous assumptions about their level of authority, and it was her job to prevent those assumptions from harming patients. And those assumptions, though she'd never admit it publicly, seemed particularly common among young doctors of color who she believed hadn't fully earned their positions through the traditional channels. Marcus Johnson had arrived at Memorial General 3 weeks earlier as the new chief of emergency medicine, though his appointment had been kept confidential while the hospital completed administrative procedures. At 34, he was the youngest department chief in the hospital's 120-year history, a position he'd earned through exceptional skill, innovative emergency protocols, and a work ethic that had impressed even the most senior physicians on staff. His journey to this role had been extraordinary. Harvard Medical School, emergency medicine residency at Massachusetts General Hospital, fellowship in trauma surgery at Johns Hopkins, and board certifications that placed him among the elite emergency physicians in the country. But Marcus understood that his youth and race made some people question his credentials, despite his Harvard diploma and the successful outcomes that had built his reputation. This Thursday evening was particularly busy in the emergency department. A multi-car accident had brought in 6 trauma patients simultaneously, stretching the department's resources and requiring precise coordination between multiple medical teams. Marcus had been working for 14 straight hours, moving seamlessly between patients while coordinating care with surgical teams, intensive care units, and trauma specialists. As the newest member of the medical staff, Marcus was still learning the personalities and dynamics of the emergency department team. He'd been intentionally keeping a low profile while he assessed how the department functioned, wanting to understand the existing culture before implementing any changes to protocols or procedures. Patricia was conducting her evening medication review when she noticed a young black doctor she didn't recognize working at the bedside of Mrs. Henderson, a 67-year-old cardiac patient who had been brought in with chest pains and irregular heart rhythm. The doctor appeared to be adjusting medication dosages and updating treatment protocols, actions that required attending physician authorization according to hospital policy. From Patricia's perspective, this looked like another overconfident resident exceeding his authority, possibly making changes that could compromise patient safety. She'd seen this pattern before. Young doctors who assumed they knew better than established procedures, thinking they could impress supervisors by taking initiative beyond their training level. "Excuse me," Patricia said as she approached the bedside, her voice carrying the authority of someone accustomed to correcting medical students and residents. "You can't prescribe that medication." Dr. Marcus looked up from Mrs. Henderson's chart, genuinely confused by the interruption. He'd been adjusting the patient's cardiac medication based on her latest lab results and ECG readings, a routine decision that fell well within his responsibilities as the attending physician overseeing her care. "I'm sorry," Marcus replied politely, though he could sense the tension in the interaction. "This is the appropriate medication protocol for her cardiac condition." Patricia's expression hardened. In her 20 years of emergency nursing, she'd learned to trust her instincts about medical hierarchy, and something about this situation felt wrong. "I don't know who you think you are, but only senior physicians can authorize those dosages." The confrontation was beginning to draw attention from other staff members. Dr. Jennifer Adams, a senior emergency attending, paused her own patient rounds to observe the situation. Respiratory therapist Mike Rodriguez stopped his equipment check to listen. Even some of the patients' families in nearby areas were beginning to notice the raised voices. Marcus realized that this situation required immediate resolution, both for the sake of his patient's care and for the professional atmosphere of the emergency department. He reached into his white coat and pulled out his hospital identification badge, which clearly displayed his name, photo, and title. "Dr. Marcus Johnson, Chief of Emergency Medicine." "Nurse Williams," Marcus said calmly, reading her name tag, "I understand your concern for proper protocols, but I am the attending physician responsible for this patient's care. Here's my identification." Patricia examined the badge with obvious skepticism, her confidence beginning to waver as she processed what she was seeing. The identification appeared authentic, bearing all the proper hospital seals and security features, but she struggled to reconcile the young man standing before her with her mental image of what a department chief should look like. "This says you're the chief of emergency medicine," Patricia said, her voice losing some of its authority as doubt crept in. "That's correct," Marcus replied patiently. "I've been chief of emergency medicine here for 3 weeks. Henderson is my patient and I'm adjusting her cardiac medication based on her current condition and lab results." Dr. Jennifer Adams approached the group, recognizing that the situation required senior intervention. She'd worked with Marcus for the past 3 weeks, and had nothing but respect for his clinical skills and leadership abilities. "Is there a problem here?" Dr. Adams asked, though she'd overheard enough of the conversation to understand the basic issue. "Adams," Patricia said, clearly flustered, "this person claims to be the chief of emergency medicine, but I've never seen him before, and he looks too young to hold that position. I was trying to ensure that proper protocols were being followed." Adams looked between Patricia and Marcus, understanding immediately what had occurred. "Nurse Williams, this is indeed Dr. Marcus Johnson, our chief of emergency medicine. He's one of the most skilled emergency physicians I've ever worked with, and Mrs. Henderson is absolutely under his care." Patricia felt her face flush with embarrassment as the reality of her mistake became clear. She'd challenged the hospital's department chief, questioning his authority and competence based on assumptions about his age and appearance. "Dr. Johnson," Patricia said quietly, "I apologize. I didn't realize." Marcus could see the genuine distress in Patricia's expression, and despite his frustration with the situation, he recognized an opportunity for education rather than punishment. The emergency department was a high-stress environment where clear communication and mutual respect were essential for patient safety. "Nurse Williams," Marcus said, his voice remaining calm and professional, "I understand that you were trying to protect your patient and ensure proper protocols were followed. That's exactly the kind of vigilance we need in emergency medicine." He paused, choosing his words carefully. "However, I think this situation highlights the importance of verifying information before making assumptions. In the future, if you have questions about a physician's credentials or authority, I'd encourage you to check with nursing supervision or simply ask to see identification rather than making public challenges that could compromise patient care. Patricia nodded, though she was still processing the magnitude of her error. Dr. Johnson, I'm truly sorry. I hadn't seen you before, and I made an assumption that was clearly wrong. The emergency department operates around the clock with rotating staff and different shift schedules, Marcus replied. It's not uncommon for team members to encounter colleagues they haven't met before. What's important is that we learn from this experience and use it to improve our communication and teamwork. Dr. Adams observed the interaction with approval, impressed by Marcus's handling of what could have become a much more difficult situation. His response demonstrated the leadership qualities that had made him successful as department chief: the ability to educate rather than humiliate, to focus on solutions rather than blame. Johnson, Adams said, would you like me to introduce you to the nursing staff, who might not have had the opportunity to meet you during shift changes? That's an excellent idea, Marcus replied. I think it would be beneficial for all of us to have better communication and recognition among team members. Over the next few minutes, Dr. Adams introduced Marcus to several nurses and support staff members who worked different shifts or had recently joined the emergency department team. The introductions were professional and cordial, helping to establish the personal connections that made healthcare teams function effectively. Patricia observed these interactions, beginning to understand that her error hadn't just been about one doctor. It represented a broader failure to recognize and respect the diverse leadership within the hospital. She'd made assumptions based on age and race that had no bearing on medical competence or professional authority. As the evening progressed, Marcus completed his patient rounds while Patricia continued her nursing duties. The immediate crisis had passed, but both understood that the incident would have lasting implications for their professional relationship and the broader emergency department culture. During her break, Patricia sought out Marcus's office on the third floor. She'd spent the past hour thinking about their encounter and realized that a more private conversation might help address the underlying issues that had led to her mistake. Johnson, Patricia said when Marcus answered her knock, I was wondering if I could speak with you privately about this evening's incident. Marcus invited her in, gesturing to one of the chairs across from his desk. His office was modest but professional, with medical journals, patient care protocols, and emergency medicine references filling the bookshelves. His Harvard diploma and board certifications hung on the wall along with photos from medical conferences and emergency response training. I wanted to apologize again, Patricia began, but I also wanted to understand how I can do better in the future. I pride myself on being a professional nurse who puts patient care first, and I'm troubled by what happened tonight. Marcus appreciated her willingness to engage in this difficult conversation. Patricia, may I call you Patricia? I think your intentions were good. You wanted to ensure that patients were receiving appropriate care from qualified physicians. That's exactly what we want from our nursing staff. But I made assumptions, Patricia interrupted. I saw a young black doctor and immediately assumed he couldn't be in a position of authority. That's not who I want to be, and it's not the kind of nurse I want to be. Marcus nodded thoughtfully. The reality is that healthcare is changing. We have more diverse leadership, younger specialists who've completed accelerated programs, and different approaches to medical training. Some of these changes can be surprising if we're not prepared for them. How do you handle these situations? Patricia asked. I imagine this isn't the first time someone has questioned your authority. Marcus was quiet for a moment, considering how much to share about his experiences. Unfortunately, you're right that this happens periodically. I've learned that most of the time people aren't intentionally discriminatory. They're working from assumptions and expectations that may not reflect current reality. He continued. What helps is focusing on patient care rather than personal reaction. When someone questions my authority, I try to provide information calmly and then redirect the conversation toward what's best for our patients. Patricia listened intently, beginning to understand the additional challenges that Marcus faced in his role. Is there anything specific that I can do to support you and other physicians who might face similar situations? Actually, yes, Marcus replied. The most helpful thing is for experienced staff members like you to help educate newer team members about the diverse leadership in our department. When you orient new nurses or students to the emergency department, you could mention the different department heads, their backgrounds, and their expertise. I can definitely do that, Patricia said. Are there other ways I can help improve our team dynamic? Marcus thought about the broader implications of their conversation. I think having more informal opportunities for staff members from different shifts and departments to meet each other would be helpful. Sometimes these misunderstandings happen simply because people don't know each other personally. They discussed several ideas for improving communication and recognition among staff members, including brief team meetings, updated photo directories, and more structured introductions for new personnel. As their conversation concluded, Patricia felt that she'd gained valuable insight into both her own assumptions and the challenges faced by colleagues she hadn't previously considered. Dr. Johnson, thank you for taking the time to discuss this with me. I promise that I'll do better in the future, and I'll work to help create a more inclusive environment for everyone. Marcus stood to shake her hand. I appreciate your willingness to have this conversation, Patricia. It takes courage to examine our own assumptions and commit to change. The incident between Dr. Marcus Johnson and Nurse Patricia Williams became a catalyst for broader changes within Memorial General's emergency department culture. Adams, impressed by how both individuals had handled the situation, proposed a series of initiatives designed to improve communication and recognition among staff members from different backgrounds and experience levels. The hospital implemented monthly team meetings where department heads could introduce themselves to staff members from other shifts, creating opportunities for personal connections that prevented future misunderstandings. They also updated the emergency department's orientation program to include more comprehensive information about the hospital's diverse leadership and the various pathways that brought physicians to their current roles. Patricia became an advocate for inclusive practices within the nursing staff, using her experience with Marcus as a teaching tool for younger nurses who might make similar assumptions. She helped develop scenarios for training programs that addressed unconscious bias and appropriate ways to verify credentials when questions arose. Marcus continued to excel in his role as Chief of Emergency Medicine, but the incident reinforced his commitment to mentoring young physicians from diverse backgrounds who might face similar challenges. He began participating in medical school recruitment programs and professional development initiatives designed to support underrepresented physicians in leadership roles. 6 months after their initial confrontation, Patricia and Marcus had developed a strong professional relationship based on mutual respect and shared commitment to excellent patient care. Their collaboration became a model for how difficult situations could be transformed into opportunities for growth and improved teamwork. The emergency department at Memorial General continued to provide exceptional critical care, but with a renewed emphasis on recognizing and respecting the diverse talents and backgrounds of all team members. The lesson learned from one evening's misunderstanding had created lasting positive changes that benefited both staff and patients. For Marcus, the incident served as a reminder that breaking barriers in medicine required not just exceptional skill and knowledge, but also the patience and wisdom to educate others while maintaining the focus on patient care that had brought him to his leadership position in the first place. 2 years later, the Johnson Protocol, named in honor of the Chief of Emergency Medicine whose grace under pressure had transformed a potentially divisive incident into a learning opportunity, had become the gold standard for addressing bias and improving communication in healthcare settings across the region. Memorial General's success in creating a more inclusive emergency department environment had attracted attention from other hospitals facing similar challenges with diverse leadership and generational changes in medical practice. The hospital's training programs were being replicated at medical centers throughout the Midwest, and both Marcus and Patricia had become sought-after speakers at nursing and medical conferences. Patricia, now serving as the emergency department's diversity and inclusion coordinator in addition to her nursing duties, often shared the story of her encounter with Marcus as a powerful example of how unconscious bias could affect even the most well-intentioned healthcare professional. Her willingness to acknowledge her mistake and commit to change had made her an effective advocate for examining assumptions and improving team dynamics. The incident had also led to Marcus being appointed to the hospital's board of directors, making him the youngest board member in Memorial General's history. His leadership in transforming a challenging situation into positive organizational change had demonstrated the kind of vision and judgment that the hospital needed as it navigated an increasingly diverse healthcare landscape. Patient outcomes in the emergency department had improved measurably since the implementation of the Johnson Protocol, with better communication and reduced conflicts contributing to more efficient care delivery. The protocol had proven that addressing bias wasn't just morally right, it was medically beneficial, creating environments where all healthcare professionals could perform at their highest level. The emergency department became a model for inclusive healthcare delivery, demonstrating that excellence in patient care was enhanced, not compromised, by diversity in leadership and staff. The protocol showed that when healthcare professionals committed to examining their own biases and treating all colleagues with respect, the entire system of care improved. And every day, as Marcus made his rounds through the emergency department, he did so knowing that real change was possible when people had the courage to confront uncomfortable truths and commit to doing better. The department had become not just a place where medical emergencies were treated, but a symbol of how healthcare could evolve to reflect the diversity and values of the communities it served. Because sometimes the most powerful medicine comes from the moment someone realizes they've been looking at a highly qualified physician and seeing only the color of his skin, and choosing to grow from that realization rather than defend their assumption.